I'm Joe Graydon.
And I'm Terry Graydon. Welcome to this podcast of the People's Pharmacy.
You can find previous podcasts and more information on a range of health topics at peoplespharmacy.com.
The People's Pharmacy podcast is supported in part by CocoVia. CocoVia cocoflavanols support both cardiovascular health and cognitive function by promoting healthy blood flow, transporting oxygen and nutrients to vital organs and muscles, including your heart and brain.
CocoVia now comes in an even more concentrated formula with 450 milligrams of cocoflavanols, 5 times more than the leading dark chocolate bar and 15 times more than the leading cocoa powder.
CocoVia has a proprietary process that preserves cocoflavanols at the highest levels, and the product undergoes rigorous testing at every stage, which allows them to guarantee the highest level of cocoflavanols per serving and to provide the purest, highest quality product possible.
People's Pharmacy listeners can now try CocoVia for 25% off by using the code Peoples25 at cocavia.com. That's COCOAVIA.com. Millions of people suffer from back pain. In some cases, surgery is essential, but other times it can cause complications. This is the People's Pharmacy with Terry and Joe Graydon.
Mark Owens broke his back when his horse went rogue. Although he survived a terrible accident, back surgery left Mark in chronic pain. Eventually, spine surgeon David Hanscom came up with a different approach for Mark's pain. Here's Dr. Hanscom.
I actually quit my surgical practice because of situations like Mark, because we're doing surgeries on normal spines and really hurting people.
When is back surgery crucial? And when is it counterproductive?
Coming up on the People's Pharmacy, a retired spine surgeon reveals the inside story about back pain and surgery.
In the People's Pharmacy health headlines, infectious disease experts are fearful that this year's flu season could be one of the worst in recent memory. The CDC just released estimates that nearly 3,000 people have died of flu and more than 50,000 have been hospitalized this season. A record number of children have died so far. An unusual feature of the 2019-2020 flu season is that influenza B has dominated in the early weeks. Most winters, the first flu cases are more likely to be one strain or another of influenza A. The holidays may have helped spread influenza viruses from one end of the country to the other. Some flu experts worry that the type of H3N2A strain that was especially severe in Australia could wreak havoc in Europe and North America this season. It's unclear whether this year's vaccine will protect against that particular strain of influenza.
Aspirin is one of our oldest drugs. It's been a popular over-the-counter pain reliever since 1899. Although there's been controversy about its role in preventing heart attacks, cancer researchers are now excited about the potential for aspirin to prevent or control common tumors. An epidemiological study published in JAMA Network Open tracked nearly 150,000 cancer patients for more than 12 years. Those who took aspirin at least 3 times a week were less likely to die during the study. People with colorectal cancer got the most benefit. An animal study published in the journal Carcinogenesis demonstrated that aspirin slows the development of tumors in the colon, particularly in mice with a gene that makes them susceptible to this kind of cancer. The lead author suggests that aspirin promotes cancer cell death and inhibits tumor growth.
Around the turn of the 21st century, drug companies started advertising testosterone on television. They suggested that many men suffered from low T that could be reversed by using testosterone as skin patches, topical gels, or shots. The idea was that such a treatment would make middle-aged and older guys feel young again, restoring their strength, energy, and sex drive, and implicitly their erections as well. How well testosterone works for such problems and whether the benefits are outweighed by an increased risk of heart attacks or strokes has been an open question. There's no doubt that men's testosterone levels tend to drop with age, though the decline is steadier than women's lower estrogen levels at menopause. The American College of Physicians has just offered guidelines for doctors prescribing testosterone. According to the guidelines, doctors would be justified in prescribing testosterone for low libido and erectile difficulties, but not for other purposes. The effectiveness for each patient should be reviewed at least annually. The guidelines recommend intramuscular injections rather than topical testosterone because it's significantly less expensive.
Over the last 2 decades, billions of dollars have been spent seeking effective treatments for Alzheimer's disease. The majority of the money has been spent trying to combat beta-amyloid brain plaque. To date, none of that research has been fruitful. A new study in the journal Neurology challenges the prevailing hypothesis behind most of those drug studies. The investigators detected memory deficits and cognitive dysfunction prior to beta-amyloid plaque buildup. They concluded that amyloid might be a reaction rather than a cause of Alzheimer's disease.
For years, nutrition scientists have suspected that magnesium is important for heart health. A new study confirms their suspicions. Researchers evaluated more than 14,000 participants in the atherosclerosis risk and community studies over 27 years. Those with low serum magnesium early in the study were 28% more likely to develop coronary artery disease. Scientists still don't know whether increasing serum magnesium with supplements or dietary adjustments would reduce the risk of heart disease. But foods like leafy vegetables, whole grains, nuts, and legumes are considered helpful in maintaining healthy magnesium levels. And that's the health news from the People's Pharmacy this week.
Welcome to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. Today we're talking about back pain and spine surgery. How could you tell if you needed back surgery? Later in the show, we'll talk with spine surgeon Dr. David Hanscom, but we want to start with a story from one of his patients.
Mark Owens worked in Africa as a wildlife scientist. He had numerous risky adventures there, but it wasn't until he returned to the U.S. and was riding a horse on treacherous terrain that he broke his back in a horrific accident. He endured multiple spine surgeries for the resulting chronic pain. Then he met Dr. David Hanscom, who changed his entire approach to his back pain.
Welcome back to the People's Pharmacy, Mark Owens.
Well, thank you, Joe. It's nice to be here, and I appreciate your hosting me.
So, Mark, you've done some pretty astonishing things throughout your life. You've been in some very dangerous situations, but it was a horseback riding accident that really took you out. Can you describe what happened?
Well, yes, I was riding up with a friend up in the mountains above Libby, Montana, in the Cabinet Mountains, actually, looking for grizzly bears. I'm a wildlife biologist, field researcher, and we were looking for signs of grizzly bears, and we were coming out in the dark that night after riding way up in the mountains, and my horse suddenly blew up under me and went tearing off down the trail in pitch dark and threw me off at high speed, and I landed across a limb which crushed my chest from the left side and then broke my back in 2 places and punctured my lung and left me to die up there.
Well, I'm sure it wasn't intentional on the horse's part, but that was the outcome.
I'm not so sure, Joe.
Oh. Well, in any event, obviously, you could have died.
I could have. I almost did from hypothermia by the time search and rescue got to me and hiked me out to a helicopter landing spot by dawn. So, yes, it was close, and they flew me to Kalispell Regional Hospital in Montana, and I had an emergency surgery, and they put about 14 inches of a ladder of steel in my back to stabilize my spine, and And that began actually my journey through chronic pain for 9 years. At that point, I went home thinking I was going to be somewhat limited, but actually I remember well, my surgeon said, Ned Wilson said to me as I was leaving, now, Mark, the rest of your life is going to be a lot about pain management. And I only half heard him because I thought, well, I can do better than that. I've overcome a lot of things. I can do better than just sort of tolerating a little bit of pain.
What was that like?
Idea.
I mean, what did you end up dealing with for 9 years? What was that pain like?
Well, it's hard to describe to anyone who's never had acute chronic pain, but I would, I don't even hardly know where to begin because it's so otherworldly. It's difficult to find commonality between what people normally experience in pain and people who have chronic pain for years that's so acute. But the first thing, I guess I'll start by waking up in the morning. You open your eyes, and the first thing you get is a lightning bolt of pain to your lower back and your legs, and it's so intense you can. It would take me minutes to get out of bed, minutes before I could support myself on my feet. When it was really bad, I was walking around hanging onto furniture if I was walking around at all. It just dominates your life. It's like having a leech attached to you that's sucking your vitality away moment by moment, every moment of your life. And even when you're asleep, you're not really asleep because the pain is gnawing at you.
And this went on for how long?
9 years, basically.
Did you ever lose hope?
I did almost. I after my second surgery, I was in such horrendous pain that I actually reached for a bottle of analgesics 3 times to end my life. For some reason, I stopped myself.
Mm-hmm.
And
well, tell us about your interaction with Dr. Hanscom, and in particular, his recommendation to begin expressive writing. Tell us what that is.
Okay.
What are the steps? What's the daily practice? How long you do it each day? I mean, really give us a sense of what that means.
Okay. Well, I was, over the years between my accident and at 2006 and after my second surgery in 2012, I'd seen probably around 10 different surgeons, and most of them recommended extreme surgeries that would break my back in a couple of places and replace the hardware with a ladder of steel, and on and on and on. And all of it was just really extreme and high risk and with very little chance of much of a recovery. And I left the office of the last surgeon who recommended all that, and I said to my friend, I've got to have a second opinion. So I found my way to Dr. David Hanscom in Seattle, and David looked at my images and then walked in, and the first thing he said to me was, I'm afraid I'm not going to recommend surgery. And I just looked at him and my jaw dropped, and I said, you can't be. I said, but everybody I've seen for years has said I have to have surgery. And he said, well, I don't see anything in your images that warrants surgery, and I'm not going to operate unless I can find a one-to-one correspondence between what the dysfunction in your back and the actual pain you're feeling, and I don't see that, he said. And that's when I really felt hopeless. I thought, oh my God, if he's not going to cut me, I'm not going to be okay, in a sense, is what I was thinking. And I said, well, what am I supposed to do? I'm not imagining this pain. And he said, no, it's real, all right, but it's not coming from your back. It's coming from your brain. And I just thought, what is he talking about? It's coming from my brain. And he went on to explain that after one experiences extreme pain for more than 2 months or so, the brain rewires itself to support that pain signal, whether or not the dysfunction in a distant limb or part of your anatomy actually is involved in the pain. It's rather like the phantom limb syndrome, where the doctor amputates, but the pain is still there after the limb is gone.
So tell us about expressive writing and why something like that could help.
Yeah, so David said, well, you can start on this new journey to try to rid yourself of pain without surgery by doing something we call expressive writing. And I said, well, what's that? And he said, well, you sit down in the morning for 15 minutes and at night for 15 minutes, and you write down every negative thought that comes into your mind, and you write it down longhand. And as you generate each one, you tear it up individually. You don't wait for a whole page. You tear up each one as you write it. And I just looked at him and I said, I got to tell you, I said, these were my exact words. I said, doctor, this seems like snake oil to me. And he said, well, you can be cut if you want to. You can be filleted like a salmon if you want to, but you may as well try this. And he said there's a lot of research out there that suggests that writing these thoughts down, these negative thoughts in the morning and at night, creates a distance between the thought and the wiring in your brain, and it allows your brain to start rewiring itself independently of those negative neural pathways that support the pain signal. So I thought, well, what the heck, I'll give it a shot. And so I sat down for 15 minutes. I wrote out, these thoughts, and they need to be very descriptive. If you use curse words, you write them down. If they're in your head, you write them down.
And when did you first sense that something might have shifted?
I went to bed that night. I completely forgot that I had done any writing. When I woke up, that wasn't even in my mind. What was in my mind was I was waiting for the usual bolt of pain, but it didn't come that morning. I didn't remember that I'd written the night before, and I just thought, well, what's different here? And I was on my feet in a matter of a minute or so rather than several minutes. And then I remembered that I'd done that writing, and I just thought, I said to my friend, that can't be the reason. It can't be working this fast. But I tried it again that next night, and then, to make a long story short, within 36 hours, I would estimate that I was 80 to 85% pain-free after 9 years.
Be a little more specific. Help us understand this expressive writing thing. What did you write about?
Honestly, it's really a matter of writing down if you have worries about finances, you might write down, I'm afraid I'm going to run out of money before I reach the end of my life in retirement, or I've just lost the love of my life. I don't see how I can go on. But you do them individually again and in longhand. And you tear them up individually and throw them away individually. Now,
how are you feeling today?
I am amazed. I go for weeks. I just went for 3 weeks without taking one analgesic, not even a Tylenol. And I ride horses. I live on a ranch, actually a wildlife conservatory, and I use a chainsaw, and I do just about everything I did before. But I am 75, so I have slowed down a little bit.
Yeah, well.
I still ride my horses.
And do you still do the expressive writing?
I do. And I do relapse, but it works every time. Every time I relapse, I sit down and I write, and I can literally feel, not all the time, but sometimes I can, when I sit down and start writing, I can feel whatever troubling me lift right off my shoulders almost. And it sounds almost like something you do in kindergarten, but it's for real. And there are over 1,000 scientific papers out there that now support the notion that it does work. And so I highly recommend it for anybody who's under stress or torment or pain or anything. And it works with emotional pain just as well as it does with physical pain.
Mark Owens, thank you so much for talking with us again on the People's Pharmacy.
You're most welcome. I really enjoyed it. Thank you, Joe. And Terry.
You've been listening to Mark Owens describe how expressive writing was able to help him manage his back pain successfully without additional spine surgery.
After the break, we'll talk with Dr. David Hanscom about the treatment he recommended for Mark Owens.
Dr. Hanscom no longer performs spinal surgery. How did he decide to stop?
We discuss the pros and cons of spine surgery. How can surgeons rethink their process?
When is surgery useful, and how would a patient know?
How common is long-lasting back pain that doesn't require surgery? You're listening to The People's Pharmacy with Joe and Terry Graydon. The People's Pharmacy podcast is sponsored in part by Kaya Biotics. KAYA Biotics offers the first probiotics which are both certified organic and hypoallergenic.
All probiotics are produced in Germany under laboratory conditions with high-quality ingredients and under strict regulatory oversight.
The 3 available formulas are created for very specific purposes, such as strengthening the immune system, fighting yeast infections, and helping with weight loss.
To learn more about Kaya Biotics probiotics and the important topic of gut health, you can visit their website, KayaBiotics.com. That's KAYA Biotics.com. Use the discount code PEOPLE for $10 off your first purchase. Welcome back to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon.
The People's Pharmacy is brought to you in part by CocoVia, maker of high-potency cocoflavanol supplements that support cognitive and cardiovascular health. More information at cocovia.com.
Also by Verazana, an analytical laboratory providing home health tests for hormones, gut health, and the microbiome. Online at verisana.com.
Today our topic is back pain and how surgery might fit into its treatment. We just heard from Mark Owens about pain resulting from a broken back. Now we turn to the surgeon he consulted.
We're talking today with Dr. David Hanscom. He retired in 2018 from his orthopedic surgical practice, in which he specialized in correcting complex spinal deformities. His most recent book is Do You Really Need Spine Surgery? Take control with advice from a surgeon.
Welcome back to the People's Pharmacy, Dr. David Hanscom.
Thank you, Terry. I am very excited to be back on the show.
Dr. Hanscom, we have just finished speaking with Mark Owens. He has described a really remarkable recovery. I mean, most people wouldn't believe it was even possible. And I'm wondering how unusual was his recovery from what could have been an impossible back injury that never allowed him to do anything meaningful again.
Well, if you understand the details of the story from a medical perspective, it's not unusual at all. First of all, he had a spine that was normal for his age. He had some disc degeneration, which, by the way, has not been correlated with back pain. It is simply not a cause of back pain. He had nothing wrong. I actually quit my surgical practice because of situations like Mark, because we're doing surgeries on normal spines and really hurting people. And Mark's story is the norm. The only thing unusual about Mark's story is that he has such a huge operation recommended, and he got better relatively quickly, but it wasn't perfect. I mean, it's ups and downs along the way, but this is what happens when chronic pain is a solvable problem. Medicine looks at it as a problem to be managed, not solved, and we see people going pain-free all the time. This is a normal story.
Dr. Hanscom, you just mentioned that you quit your surgical practice. You were identified as a spine surgeon, very skilled. Can you tell us more about that decision to stop doing spine surgery?
Well, what happened, I started surgery practice in 1985, and for 8 years I was aggressive. I thought surgery was the answer. I would feel guilty if I could not find a reason to perform surgery. And then in 1993, the data came out that said there's no data that supports doing it. The success rate for a back fusion for back pain is about 20%. So I just stopped. But I didn't know what to do, so I started myself to go into a horrible abyss of chronic pain for about 15 years. I came out of it by accident. I did not know what had happened to me. I did not know how I got into it. I did not know how I came out of it. And about 10 years ago, I started sharing these tools with my patients, again, not knowing what I was doing, and people started getting better. And then the process kept evolving. The neuroscience came up to speed, or I came up to speed with the neuroscience. And the last 5 years have just been remarkable. So I saw more and more people getting better without any interventions as far as risk. And then I saw people every week, 3 to 5 times every week, they're having major surgeries done on normal spines. And I saw a situation where I saw a couple of people literally paralyzed with surgeries that they didn't need. And I just felt like spine surgery is so out of control right now. I just felt like I had to do what I could do to stop this juggernaut of spine surgery.
Let me interrupt you right there, because you said that you were doing a lot of, I think you said lumbar fusion. Was that what you referred to?
Right.
What is that?
Right. So right now, this is what's ironic. So lumbar fusions are when you weld the spine together, 1 or 2 levels, to stabilize the disc to stop the pain. What's ironic is that disc degeneration, which is the reason to do the surgery, has been well documented to not be a source of pain. So we're doing an operation to solve pain on a structure that's been documented to not be a source of pain. With Mark Owens, he just has some bone spurs and degeneration. That was it. And we also know that acute pain resides in the pain part of the brain. Chronic pain goes to the emotional center. It's a completely different problem. So what you have to do, you have to rewire the circuits. And what happens, we're actually doing these major interventions without any data. There's not one research paper that documents that we should be doing a fusion for back pain. There's absolutely no papers that document that we are methodically applying known principles to solve pain. And in my book, Back in Control, it's really just the standard of medical care. There's nothing new in that book. They're all well-established, deeply established medical practices. For instance, Mark, I'm sure, talked about the expressive writing. There's over 1,000 research papers that document the effectiveness of expressive writing. Dr. Pennebaker, who's been on my podcast, started this in 1982. I interviewed him about 6 months ago, and over 1,000 research papers that document that this little technique, simple technique, simply writing down your thoughts, tearing them up, changes autoimmune disorders, asthma, colitis, anxiety, depression, student performance, athletic performance. It's unbelievable. I never heard about it. Nobody taught me that in medical school, residency, training, or fellowship. Nobody ever taught this to me. So I'm going, why? So again, not one research paper that documents that a spine fusion works for back pain. It's up over $10 billion a year in the United States. The downside is actually about 40 to 50% chance of making you worse, and only about a 20 to 30% chance of making you better. It actually has almost double the chance of making you worse than it does making you better.
Dr. Hanscom, my uncle was a farmer, a dairy farmer, and he said farmers like to plow and surgeons like to cut.
Absolutely.
And so how do you break out of that pattern if that's what you love doing and that's what you've been trained to do? How do you step back from the urge, the old phrase, when all you have is a hammer, everything looks like a nail? How do you help your colleagues rethink that?
They're not. That's why the patient has got to take responsibility for his or her own care. It's just not going to change. I mean, all the years, I have over 1,000 patients that have gone to pain-free. We have over 100 patients with surgical lesions that have gone to pain-free. Not one colleague asked me, well, God, this is really interesting. What's going on? Not one colleague asked me that question. So the surgeons are not going to change. I've given that up. I've tried that for 20 years, and I'm not going to become a crusader. In other words, I'm not trying to – I understand surgeons are trained this way. I was one of those surgeons myself. If I hadn't gone through my own severe chronic pain process, I never would have had any insight to what's going on. So I don't want to crucify a given surgeon, but the culture right now, the business of medicine, is actually pushing us hard to do procedures that have been documented to be ineffective.
Well, let me interrupt here and ask you when spine surgery really must be done. And let me tell you a story. A man goes into the emergency department at his local hospital complaining of lower back pain. He mentions to the nurse that he was also having some bladder problems and some numbness in his legs. But when the doctor came in, rushing around in the emergency department and asked what the problem was, the patient focused primarily on his back pain, thinking, hey, I already told the nurse about the bladder. I told her about the numbness. The nurse never told the doctor, and the information about the bladder problems apparently fell through a crack and was not communicated. And because this wasn't the first time that the patient had ended up in the emergency department with a back problem, the doctor probably wasn't too concerned. The patient was released from the emergency department with a diagnosis of a back problem. Several hours later, he was admitted to another hospital where he was diagnosed with something called CES. I don't quite know how to pronounce it, but I would guesstimate Cauda equina syndrome. And,
Cauda equina syndrome, right.
And this can sometimes lead to some pretty serious consequences if untreated. In his case, it ended up causing paralysis of the legs, permanent loss of bowel and bladder control, and probably a complete change in his life. So it seems like in this particular situation, surgery would have been necessary and it needed to be an emergency.
Well, that brings up another problem in medicine right now. The business of medicine has limited our time with patients. There's too little time, too many patients. And that's called one of the red flag symptoms. And it's really the doctor's responsibility to get the full history. Once you label a patient with whatever and don't listen to the full history, you're always at risk. So I picked up bladder cancers, pelvic floor tumors, side notch tumors, tumors in the spinal cord, because you take that extra history and you get a set of symptoms that are a little unusual weight loss, change in appetite, some fevers, etc. And when you have what's called red flag symptoms, you have to move forward. So I'm not against spine surgery. What I am against is spine surgery being done on normal spines.
Well, tell us what.
So that's a classic scenario. That's a huge problem.
What is CES?
Cauda equina syndrome. So what happens, you have a big disc rupture. It's called a central disc rupture. And the spinal cord quits at the first lumbar vertebrae. Below that, the lower back just has nerve roots floating around. Cauda equina means Latin for horse's tail. And what happens, these massive disc ruptures really squeeze the nerve roots. The other nerves that go to the bowel and bladder go to the legs. And you want to get that disc out of there within 24 hours, preferably faster. If I have a patient with even a history like that, just a hint of it, I'll actually call the operating room and say, look, get the operating room ready. We'll prepare the room. If the scan comes back negative, we'll cancel the case, of course. But if it needs to be done, we'll do it almost instantly. And we've had good success doing it that way. But no, that's a classic scenario that happens all the time with ER physicians and people moving too fast. I had one patient quadriplegic, missed diagnosis in the emergency room. Another woman who almost died of an infected spine, again, missed in the operating room. I had a relative who had a missed infection in his neck, almost died, almost quadriplegic. But yeah, medicine's moving very, very quickly, and we're not getting the full story.
Dr. Hanscom, your new book is, Do You Really Need Spine Surgery? And what you're suggesting is that if your spine is normal, I'm using air quotes, you don't need spine surgery. How would a patient know if the spine is normal?
What I did in the book is I really just defined 4 choices. One choice is this: is there a structural problem that you can see? I call that type 1 or structural. Or is the spine normal for your age? In other words, just disc degeneration, or do the symptoms match the problem? So you have to have a lesion and symptoms that match in order for it to be fixed. Then if your nervous system is calm, that's great. If your nervous system is sensitized and under a lot of stress, we do know that the surgical results are quite poor. So technically, if you take a person who's calm, relaxed, and they have a ruptured disc, surgery works well. If you're going through a divorce or some life event, it doesn't work as well, but you can still deal with it. But if there's nothing there to fix, there's nothing to do. And somehow there's somewhat of an urban legend that, okay, everything else has been tried, let's try surgery. Well, it makes no sense. There's nothing there to fix. And that's the key to the book. If I accomplish one thing with the book, is that spine surgery is only the definitive solution if you can see the problem and the symptoms match. Then it works beautifully. Probably 70% of surgery probably should not be done right now.
Now, you have a lovely graphic early in the book, a therapeutic grid, a treatment grid, in which you actually lay this out on paper, just as you have described it to us. Either there's a structural problem in which surgery is an option, and either you are feeling calm or you're under stress. The approach is different either way, although surgery is still an option for either of those. Or there's no structural problem that is connected to the symptoms. And in that case, despite whether you're calm or stressed, surgery is not an option. How does a patient go about figuring out where they belong on that grid?
Well, what I described the general nature of a structural problem. In other words, there's a tumor or infection, or say the spine's unstable, or there's a pinched nerve. Those are all structural problems. Unless you have one of those, you do not have a structural problem. Now, what happens in chronic pain, again, I will blame the medical profession, not individual doctors, but patients have severe pain. They get bounced around the medical system. The pain becomes worse and worse and worse. And, of course, they're desperate. And, of course, the pain is real. And it would make sense for something to be done definitively to solve the problem. And it's solvable by actually calming down the nervous system, not by doing a procedure. There's a paper that came out last month in the Journal of Pain that showed that no structural intervention works in the presence of chronic pain, not one, in any part of the body. Not one.
Dr. Hanscom, I'd like to share my story with you. So last year in the winter, we had a pretty good-sized snowstorm and we lost power. And foolishly, I lifted a generator, which is a very heavy piece of equipment, and within a couple days, I was in pretty serious back pain. Now, I've had back pain pretty much my whole life, and I just deal with it. Well, this time it didn't go away as it usually does, and it lasted, and after several weeks, I went to see my massage therapist. I went to see a chiropractor. They both recommended physical therapy. I began doing physical therapy. I got an X-ray. They said, "Oh, man, your back is a mess. You've got deterioration. You've got this, that, and the other thing, and let's just keep doing it." Well, a month went by, 2 months went by, 4 months went by. I was still in pretty severe pain, but then gradually over about the 5th month, it began letting up. And about 5.5, 6 months after this accident, I was back playing tennis, which made my life much happier. Bottom line, I suspect that if a neurosurgeon looked at my X-ray or CT scan or MRI, I would have probably been counseled that I needed surgery because it was, quote unquote, such a mess. But eventually, with physical therapy and these other modalities, I was able to get back to functioning. I wonder how often that happens.
All the time. That's the problem right there. That's just classic scenario textbook story. Because remember, those bone spurs have been there for years. They're still there. Something happened to your back. By the way, if we did a research MRI scan on your brain called a functional MRI scan, you had a bad back sprain, and the pain center lights up. Now, if the pain had lasted 9 to 12 months, the pain shifts from the pain center to the emotional center. It becomes memorized. Then it's a problem. And then I don't know if you had other stresses in your life at the time. That actually is a factor. Sometimes you may have the same back injury and be gone in 2 weeks. If you're going through some major life events, the same injury will last for months at a time, or it gets memorized by the rest of the brain. If you're under some personal stresses or external circumstances that are unpleasant, that ups the risk of developing chronic pain dramatically. And you're right on the edge. 6 months is sort of the tipping point where it either resolves or it can go on to become a chronic problem. But again, they're two different entities.
You're listening to Dr. David Hanscom, an orthopedic complex spinal deformity surgeon who retired in 2018 after 32 years in practice. His most recent book is Do You Really Need Spine Surgery? Take Control with Advice from a Surgeon.
After the break, we'll learn more about Dr. Hanscom's personal experience with chronic pain.
What triggered the anxiety and stress that was driving his pain?
Dr. Hanscom recommends that people direct their own care. How can they do that?
You're listening to The People's Pharmacy with Joe and Terry Graydon. This People's Pharmacy podcast is brought to you in part by Verizana.com.
Verizana Lab offers home health tests that allow you to monitor your hormones and health conditions. You can take control of the quantitative assessment of your health and learn about male and female hormone balance, the stress hormone cortisol, leaky gut, gluten intolerance, or your gut microbiome.
Take a more active role in tracking your health and take 20% off your first order of a mail-in testing opportunity with the discount code PEOPLE. That's PEOPLE, all uppercase. To learn more, go to Verizana.com. That's VERISANA.com.
Welcome back to The People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. The People's Pharmacy is brought to you in part by CocoVia, offering plant-based nutrients in the form of cocoa flavanols for brain and heart health. Online at cocovia.com.
And by Kaya Biotics, probiotic products made in Germany from certified organic ingredients. That's KAYA Biotics.com.
We're discussing pain control today on the People's Pharmacy. We've been focusing on back pain and the potential role of spine surgery in treating it. But millions of people have to deal with many other types of chronic pain. What can they do?
Our guest is Dr. David Hanscom, orthopedic complex spinal deformity surgeon who retired in 2018. Today, Dr. Hanscom's mission is to reintroduce true healing into medicine. His books include Back in Control, a surgeon's roadmap out of chronic pain. His most recent book is Do You Really Need Spine Surgery? Take Control with Advice from a Surgeon.
Dr. Hanscom, you learned about chronic pain firsthand. Can you tell us about your personal experience with chronic pain and what you learned from it?
Well, what I've learned is that anxiety is the pain. It turns out that emotional pain and physical pain go to the same part of the brain. You get the same chemical response. The problem that humans have is that they can't escape their thoughts. And what happened, I was a master at suppressing stress. My attitude was bring it on. I went to one of the top spine fellowships in the world. I was a high-level spine surgeon for many years. Spine surgery is considered one of the most stressful practices in medicine. And I did it. I was fine. I went from being a fearless surgeon to crippling anxiety in one day and did not come out of the hole for 13 years. I thought the anxiety was psychological. It is not. Anxiety is just a sensation generated by your stress chemicals. The problem is this survival response is a million times stronger than the conscious brain. Every human being has this anxiety survival response. Anxiety is just the sensation generated by your survival hormones like adrenaline, cortisol, and histamines. Just like laying on the beach full of oxytocin, dopamine, and serotonin, you feel relaxed. But relaxed is not a diagnosis, and neither is anxiety. It's just a symptom. And the key issue, what I've found out over years, is that what really drives people insane, literally, with pain is actually the mental pain. So it's driving the opioid epidemic. Of all my symptoms that I had for 15 years, the anxiety was relentless. It was unbearable. I was suicidal. And the physical pain was what it was. If I give my patients a choice of saying, look, I can do surgery to get rid of your leg pain or your arm pain, or I can get rid of your anxiety, you can get rid of your anxiety, everybody wants to get rid of the anxiety. The anxiety is just unbearable. And it's supposed to be unbearable because it's a survival sensation that compels you to take action to resolve it. Humans can't escape their thoughts, so all of us are subject to some level of anxiety based on our background and our level of intrusive thoughts. But it turns out that's why, in essence, I quit spine surgery, because we're doing surgical procedures on anxiety. We're doing physical interventions for mental pain. And that's the essence of the problem.
Do you miss spine surgery?
Yep. I like being part of the team. I like talking to patients. I like seeing people get better. We'd have weekly team meetings, literally training people how to do chronic pain better. But we had sort of a SWAT team approach. We were really good at this. And so, yeah, I miss it. I like my colleagues. I like the atmosphere, being in the trenches. I mean, surgeons, as you know, where we like to work. But I'm learning. I won't say I'm retired. My wife says I'm refired. I've just fired up again, going in a different direction. But yeah, I like taking care of patients and like seeing them get better. We just had the best time. I mean, the data shows only 20% of physicians actually are comfortable managing chronic pain. Less than 1% enjoy it. And I have to tell you, it's become by far and away the most enjoyable part of my career is to take people without any hope and watch them come out of the hole. I mean, I just heard a story last week of a gentleman I never met. He worked at the pain psychologist in Sacramento. He's a gang member who had lost his leg in a shooting. He developed severe phantom limb pain. He was not a nice guy, angry, vindictive, chewing off medical system, high-dose narcotics. Within 3 months, his pain disappeared, no narcotics. He's going back to school to become a drug counselor.
That is a great success story.
But we hear these all the time, just different variations of it. So chronic pain is curable, and the medical profession doesn't see it that way. But yeah, there's a small handful, probably less than 0.5% of us in this country are seeing what each other is seeing, is that chronic pain is a solvable problem. But again, the mental pain is by far and away the bigger problem. You have the bipolar, depression, teen chronic pain, the suicides, the opioids are all driven by mental pain. And again, the core issue is anxiety, which is not psychological, it's neurochemical. And by missing the diagnosis right now and treating it psychologically, we're really doing a disservice to our country. I have 15 people right now that are friends of friends that I'm coaching and just calming them down, and the pain's disappearing.
Can I ask what it was that triggered your chronic pain? What emotional or anxiety experience brought this on?
When I look backwards, one of the symptoms, of course, is migraine headaches. Those actually started when I was 5. I was raised in an extraordinarily abusive background. I had a mother who basically, in retrospect, was psychotic, bipolar, rages, angry, physically abusive. And so I didn't realize that was not normal, of course. And then I developed ringing in my ears, burning in my feet, headaches, back pain, neck pain. My feet started to burn. I developed PTSD. There's over 30 symptoms that translate, because what happens when you have sustained exposure to elevated stress chemicals, each organ responds in its own unique way. That's why there's over 30 physical symptoms that come from these elevated levels of stress chemicals. And so I had 17 of them at the same time. I was miserable beyond words. I'm fine. And it started with this technique I think Mark talked about, is expressive writing. There's over 1,000 research papers that I now know about that document that it works. When I work with my patients to pull them out of chronic pain, it's a simple exercise. You simply write down your thoughts and you tear them up. And then what you're doing, you're actually breaking through these obsessive circuits. I call it phantom brain pain, just like phantom limb pain. But somehow the writing, I call it a mental jackhammer, it somehow breaks through these circuits. When I asked Dr. Pennybaker how it works or why it works, he goes, I don't know. But some type of externalization of your thoughts is that you cannot escape your thoughts, but you can separate from them. And so, yeah, after 15 years of doing everything, I'm a physician. I had every access to everything you could imagine. That simple act of starting the writing exercises started to break up my pain. And within 6 weeks, I was quite a bit better. Within 6 months, I was fine.
Now, tell us just a little bit more about this expressive writing exercise. So it doesn't matter if your spelling or punctuation is okay. Right. You're just writing. What are you writing?
Anything. Just free thoughts. The reason why you tear them up is for 2 reasons. One of them is to write with freedom, because it's the thoughts that you suppress that become your monsters. In other words, obsessive thought patterns come from trying to suppress unpleasant, bizarre thoughts. And so writing those down is important. Writing down positive thoughts is fine. Most of the research has been done by writing down intense emotional experiences, but it doesn't really matter. There's a 3-column technique by Dr. David Burns in the book Feeling Good that also is another way of doing the writing. But what the writing does, it separates you. In other words, you can't control your thoughts, but the thoughts are on the table. You're here. And what you're doing, you're stimulating what I call neuroplasticity, which causes the brain to actually change structure. So you have an awareness and separation in one move. And then the redirecting program, where we actually stimulate your brain to change, is what I call active meditation, or even right now, just feel where you're sitting, drop your shoulders. And what you're doing, you're switching from thoughts to different sensory input. And between the awareness and separation of the writing, combined with the active meditation, that's always a starting point.
What else is helpful? And I'm thinking about some of the conditions that humans are susceptible to, whether it's anxiety or depression or PTSD, addiction to substances, whether it be alcohol or opioids. Tell us a little bit more about how this expressive writing can work for a number of conditions and what else you recommend.
So I have a website, backincontrol.com, and it puts people through a sequence that helps you reprogram your brain. So in stage 1, we have the expressive writing combined with active meditation. Another strategy, which sounds interesting, which has been very, very powerful, is not discussing your pain, no complaining. Because your brain's going to develop where it replaces attention, and if your attention's on seeking a cure, solving the problem, you're actually reinforcing the problem. That's why talk therapy alone cannot and doesn't work.
So in other words, what you're trying to do is not get people into the rut of going, oh, my back, it's killing me. The more they say that, the more it reinforces it.
Absolutely. Again, it's not a complicated process, but it is stepwise. Is that you create a vision of what do I want my life to look like? It's like learning a new language, and then how do you execute that plan? In other words, you don't learn French by trying not to speak English. You're not going to learn how to come out of chronic pain by trying to fix the pain. And so what you're doing, you create a vision of what you want with or without the pain. And as you move towards that vision, then you don't use the pain pathways as much. It's a very paradoxical process. That's why it's effective. Because your brain changes every second. It's called neuroplasticity. Every second your brain develops new neurons, new connections, new myelin. Your brain changes continually, and what you're doing, you're guiding the brain to change the direction that you want. If you don't do that, the default language is survival. Relentless anxiety is what your body is supposed to do to survive. Again, I call it the curse of consciousness. Humans cannot escape their thoughts. And so again, like this little active meditation exercise, you're simply switching from thoughts to a different sensation. The second level, which is more complex, but again, really critical, is forgiveness versus play. When you're angry, your body's full of stress chemicals at a very high level. At play, you're full of the play chemicals in a wonderful way. The essence of the solution is that you're connecting to your own capacity to heal, which allows you to auto-regulate your body's chemistry. So what you're doing, it's not psychological, it's neurochemical. As you become aware of the things that are stimulating your nervous system, you get to connect to who you are, use the tools to switch directions. It becomes stronger with repetition. And again, my prognosis was 0. I mean, people look at me and go, how can that be? I can look at any person in pain and say, look, you are suffering a lot, but you're not suffering more than I did. So not only do people break out of the pain pathways and the anxiety, most of them thrive at a level they never dreamed even possible, ever, before they went into chronic pain. And that's the exciting part, which also motivates me tremendously, is that people are so excited to be out of this hole. All of a sudden their lives start re-expanding, new jobs, new careers, they get remarried, new relationships. I mean, it's unbelievable how people thrive when they're not crushed by anxiety.
Now, Dr. Hanscom, pain affects not just the patient sitting in your office, but also the whole family. And, contrary-wise, relationships with the family could affect the patient's stress level. As a surgeon, my guess is a lot of surgeons never ask about that. Nurses might ask about it, but doctors often don't. Is that something that should change?
It has to change. I mean, it's not so hard. I mean, I had one of my fellows, it takes about 2 minutes just to ask the question, what's going on? I had one gentleman whose grandson had shot his son. I had another woman whose daughter was pregnant by her husband. We hear about suicides all the time. And remember, the bone spur has been there for a long time, and something changed to cause the leg pain or the arm pain, and what usually has changed are circumstances. I mean, people really suffer. And in chronic pain, people suffer also because of the pain in addition to the circumstances. So we know people in chronic pain die on the average of 7 years earlier than people without pain. There's double incidence of cardiac disease, depression, hypertension, obesity. All those go higher in people in chronic pain. So again, the pain is a reflection of elevated stress chemicals. When you're under sustained assault from these chemicals, it's like driving your car down the freeway in second gear. It's going to break down. So yeah, really taking the time. In fact, that's the one thing that would change medicine directly is simply paying doctors to talk to the patients. Absolutely.
Dr. Hanscom, we're almost out of time. I wonder if you can share with our listeners what you are trying to accomplish, not just for people with back problems like me, but for patients in general. When you wrote, "Do you really need spine surgery? Take control with a spine surgeon's advice," what would you like them to understand about this entire process?
The main thing is just be open to new ideas. This is all standard medical knowledge. Right now, the business of medicine has marketed solutions, but they have to tell you there's something wrong with you first. I understand the marketing, I understand the promise of a cure, but really be open to learning about the problem and taking charge of your own care. Is actually not very hard, but being open to change is the one necessary tool to actually create the change.
And what do you mean by taking control? Because I think a lot of patients, especially when they see a neurosurgeon, they think, well, this doctor is God. I mean, this physician knows everything. I'm just the poor patient in pain. How do you help people direct their own care?
Well, the first book, Back in Control, gives you lots of tools to actually just calm yourself down and make better decisions. For instance, sleep. If you're not sleeping, you can't think clearly. So that's just one example. But with surgeons, that's why I wrote the book. But it's a resource for patients, but also for other healthcare providers to say, look, Mr. Surgeon, there's nothing wrong. And really, surgery, spine surgery in particular, has become predatory. I mean, it's unbelievable how aggressive surgeons are. The data shows only 10% of surgeons are actually acknowledging the factors that affect outcomes before they recommend surgery. 10%. And their report is, well, I'm a surgeon. I don't have to deal with these other issues. Wrong. We're physicians. We're not technicians. So even though you may not do the treatments yourself, I get it. As a surgeon, you're still responsible to make sure these variables are covered before you make the decision to do the surgery. And right now, that story is not happening in most surgeons' heads. And people are having major operations done on the first visit, and it doesn't make any sense.
Dr. David Hanscom, thank you so much for talking with us on the People's Pharmacy.
Thank you. I enjoyed this very much.
You've been listening to Dr. David Hanscom, an orthopedic complex spinal deformity surgeon who was based in Seattle, Washington. He retired in 2018 after 32 years in practice. Today, Dr. Hanscom's mission is to reintroduce true healing into medicine. He feels that doctors should be given the time to listen and understand their patients. He's the author of Back in Control, a surgeon's roadmap out of chronic pain, and his most recent book is Do You Really Need Spine Surgery? Take control with advice from a surgeon. His website is backincontrol.com.
Lynn Siegel produced today's show. Al Wodarski engineered. Dave Graydon edits our interviews.
The People's Pharmacy is produced at the studios of North Carolina Public Radio, WUNC.
The People's Pharmacy theme music is by B.J. Liederman.
The People's Pharmacy is brought to you in part by Verizana, an analytical laboratory providing home health tests for hormones, gut health, and the microbiome. Online at Verizana.com.
Also by Cocoa Via, maker of high-potency cocoflavanol supplements, supporting cognitive and cardiovascular health. More information at cocovia.com.
And by Kaya Biotics, probiotic products made in Germany from certified organic ingredients. KAYA Biotics.com.
If you would like to purchase a CD of today's show or any other People's Pharmacy broadcast, you can call 800-732-2334. Today's show is number 1195. The number again, 800-732-2334, or place the order online at peoplespharmacy.com.
When you visit our site, you can share your thoughts about today's show. Have you tried expressive writing for chronic pain? We'd love to hear about your experience. Sign up for our free online newsletter. It's all there at peoplespharmacy.com. In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Please join us again next week. Thank you for listening to the People's Pharmacy Podcast. It's an honor and a pleasure to bring you our award-winning program week in and week out. But producing and distributing this show as a free podcast takes time and costs money.
If you like what we do and you'd like to help us continue to produce high-quality, independent healthcare journalism, please consider chipping in.
All you have to do is go to peoplespharmacy.com/donate.
Whether it's just one time or a monthly donation, you can be part of the team that makes this show possible. Thank you for your continued loyalty and support. We couldn't make our show without you.